Okay, that's everybody, I guess. Good afternoon, everyone. This is the Health in the Public Interest Master's Program Seminar Series. We're real happy to have an audience of students and outside folks today, as we usually do. And, I was just thinking about the great audience that we have each week. If you have friends, colleagues, interested people who might benefit from listening to our seminars, feel free to give them our address or to share the link with them in the future. And it's kind of a growing thing. And I see that we have at least one former student out there too. So they're usually part of the audience as well. So the Public Health in the Public Interest Program, which we call the HAPI program, HAPI, is a program that's designed to be not a typical public health program, but a program in the general area of public health that emphasizes the social determinants of health, the effects of pharmaceutical marketing, of culture, society, looks at distribution of healthcare services, underserved populations, etc. And if you're interested in the program, you can go to our website. It's simply hapi.georgetown.edu, and we'd love to talk to you about the program if you're a potential student as well. So this morning we have Cate Oswald from Partners in Health speaking, and she'll be introduced momentarily by Anya Hirschfield, one of our current students. I just wanted to point out that it's a great transition. Last week we had a on the streets physician who was dealing with underserved people one at a time in DC, going out and finding those people and working with them to try to institute some healthcare. And today we're going to look at something that's, I think, going to touch on global health and what organizations can do, and also what people working in those institutions can do. So we're going to have about 45 minutes for Cate to speak, and then we're going to have you muted during that time unless Cate asks otherwise, and we're going to then open it up to questions, first from students and then from the outside audience. We ask the students to address your questions on mic. Outside people can use the chat function from the very beginning to put in comments or ask questions, but Kate's going to be talking, so she'll probably get to looking at those later, or the moderator can sift through them as well. So with all that said, I welcome everyone and look forward to a great seminar by Cate, and turn this over to Anya.
Hi. So as the moderator for this week, I have the absolute honor of introducing Cate Oswald. Cate is the Principal Chief Program Officer for Partners in Health and serves to ensure that PIH's mission and theory of change are achieved. Starting her career in health equity, she earned her MPH in epidemiology and program design and a bachelor's in international development and community health. She now leads the charge for PIH's strategy and engagement with government and institutional partners, working hand in hand with PIH colleagues around the world. Cate is a passionate advocate for universal healthcare, social justice, and global health equity. She says it's been her great honor to live deeply in community with her patients and colleagues for 15 of the 18 years of her career with PIH. Cate also has extensive experience working on issues of health and social justice in Rhode Island and Massachusetts through homeless rights initiatives. Outside of her accolades within the United States, Cate has truly made an impact around the world. She has worked in Sub-Saharan Africa, South America, the Caribbean, and the South Pacific on initiatives aimed at understanding the social context of disease, while working hand in hand with communities and governments to improve health outcomes and fight for structural change. She also serves as a course leader and instructor in Brown University's Leadership Institute Global Health Program. In addition to this stacked repertoire, Cate also has a 5-year-old who started kindergarten earlier this month, so she often finds herself in the midst of elaborate Lego building sessions these days. So Cate, thank you so much for being here, and take it away.
Thank you, Anya. That was a great intro. And as you can see, I'm very honored and excited to be here speaking with all of you, and just to have this platform to share a little bit more about the work that I've had the great honor and privilege of being a part of. I wouldn't just call it work, I'd call it a movement for health equity the last 18 years. And coming from a really quite uh, what's the right word? A complex set of meetings last week at the UN and in New York around certainly around the impact of climate change on health. There were 3 high-level meetings last week: one on pandemic preparedness, one on on universal healthcare, and one on TB. It was really there were moments of hope, but there were also real, moments of realization echoed throughout all the rooms that I was in, and there were many rooms that the global financial architecture that exists now is not leading to equitable outcomes for all, and that is for sure, and is continuing a power dynamic that is really leading to greater divides. And so a lot of what I'm here to talk about today is the work of Partners in Health as certainly the direct service delivery work, but how are we also simultaneously as a social justice organization constantly working to challenge through the evidence we're generating, through the daily lived experiences, the status quo, and how are we working in the honor of our co-founder, who sadly passed away suddenly last February, Dr. Paul Farmer. How are we ensuring that the roadmap that he left us for generational change continues? And so as a current leader of PIH, and having been a student of our work in Haiti for so very many years, and a student of Paul, I'm here to share a little more about where are we now, and how can we as public health specialists continue to really deeply engage in the movement for health equity. So I have a few slides. I'm just going to pull them up. I just have to, of course, I had them all ready, and now they've moved to the end. Here we are. So certainly our work and the movement is bigger than one human, but I know many of you have heard of the incredible human that was Dr. Paul Farmer, and wanted to start off by reminding us of some of his work in the early days. So we started in 1982 in rural Haiti as in our Haitian sister organization, Zami La Sante, continue to this day to be leaders in this movement for really strengthening the public sector. But Paul's whole philosophy, and when he was a student at Harvard at med school, jumping between Haiti and Harvard every week, sometimes, to keep up with his classes, but also to keep up with the work, was this fundamental disconnect, and of the fact that there are modern medical tech, advancements that are happening on a daily basis around the world, and how are we continuing, as humanity, to ensure that all humans have access to these medical advancements. So even back in '99, years and years ago, probably before some of you were born, there was this, he noted in one of his books, Pathologies of Power, that if everyone has a right to share in scientific advancement and its benefits, which is one of the rights in the Universal Declaration of Human Rights, where are our pragmatic efforts to improve the spread of these advances? Even as our biomedical interventions become more effective, our capacity to distribute them equitably is further eroded. And then, as we can see in Article 25 of the Declaration, and the right of everyone to enjoy the benefits of scientific progress and its applications, or the right to science, really means that governments have a duty to make available and accessible to all persons without discrimination the highest attainable standard of health. And for us, this has been a driving force of our work from day one, and it was why the initial cohort of patients that were started on antiretrovirals in the late 90s, early 2000s in Haiti, that first cohort of 50 patients that were written up in the Lancet became not only a rallying cry for PIH, but for the world to really push to demonstrate what's possible, and to ensure that that certain advancements were accessible. And I started with this because I feel that we just went through, yet again, 20 plus years later, the same exact challenges that we through with COVID, and the access to vaccinations and to treatments and even to diagnostics that we're still fighting today. So I wanted to talk a little bit about Partners in Health's Theory of Change. We are now a movement of 20,000 workers paid through PIH, most of whom are community health workers, 99% of who are from the communities where we serve. So there's a number of us that are not that are living in the U.S. or other countries where we don't have direct daily care delivery work, but who are the large majority of us are leaders, frontline health workers, drivers, cooks, community workers, and scientists, researchers, teachers from the communities where we continue to have daily presence. And so, our theory of change is really a circle for a reason. It starts with care, because the large majority of what we're still doing today is gap filling and with public sector facilities. We work across 11 countries in direct service, working in public facilities to strengthen and reinforce and demonstrate what's possible. We also ensure that in each of those communities, it's not just one layer of the system that is strengthened, it's the community, primary and secondary, tertiary facilities, and that bidirectional referral pathway that are essential for ensuring that people stay well after they return from a facility. We simultaneously engage in training. Much of that is on the job, in community, at the bedside, with mentors and coaches. We have a robust quality improvement and program that is in all of the facilities where we work. We also have robust training of community health worker programs with the ministries of health, of course, and run a university for global health equity in rural Rwanda, and have partnerships with a number of public universities in all of the countries where we have care delivery work as well. And then we do a lot of our current work, and the work that my team really focuses on deeply, is how are we also influencing with evidence and ensuring that our work that we're doing in a few demonstration districts in communities and countries is not just staying as our model, but is really being built into national health reforms and policies and costed plans and national strategic plans and in regional and global policy documents like with the World Health Organization or others. But this influence with evidence component, the third component, is really not only how is the work being written up and published in academic journals, but also how is the evidence really leading to influencing policymakers and changing legislation and pushing for investments that already exist to be allocated in new ways that lead to better health outcomes and might actually be in the long run less expensive or more cost effective than a lot of vertical programs that have, only an HIV focus or only an NCD focus. So this is a map that demonstrates where we have long-term commitments and partnerships with the governments of these countries. So certainly we started in Haiti, but we now work in Mexico, in rural Chiapas, in Navajo Nation through our sister organization, COPE, which is Community Outreach and Prevention and Education Program. We work in Peru through Socios and Salud, our Peruvian colleagues, in Liberia, Sierra Leone, our newer care delivery countries where we were invited as the Ebola emergency in 2014 was so severe, we were invited by those two governments to share and spread our work in a new West African context. We work deeply in Rwanda, Malawi, Lesotho, and as of 2020, we have been invited to work deeply in the United States through we worked to stand up a community health worker model here in Massachusetts for the state during COVID that was a virtual platform of 3,000 health workers who were connecting those who were testing positive to resources to safely isolate, to have food and diaper deliveries to be able to hopefully stop the spread of COVID. We work in Immokalee, Florida, in Newark, New Jersey, in Pima County, which is right near Navajo Nation, in Illinois, in Montgomery, in Alabama, and Chicago. These are cities and jurisdictions and states that saw the work of PIH's comprehensive community model and wanted to replicate it in the US. So most of the work we do in the US now is really on technical advising and accompaniment within departments of public health. But we're also working with the North Carolina state on establishing a really successful community health worker model that we hope other states will be able to take on through Medicare funding. So we're finding new ways for the work to deeply strengthen public systems while simultaneously keeping our long-term commitments to the communities where we serve. So the reality is the problem statement that we're all up against now is, even though we've done, all of us as the global community have been fighting this fight for a long time, really working to overturn systemic inequities. The reality is that there are so many inequities that we're facing on a daily basis, and so some of the areas that we're really honing in on are this access to technologies. So not only vaccines, but diagnostics and treatments that are available that should be more accessible to others. We're really deeply troubled and facing on a daily basis the health worker shortage, not only on the African continent, which it's most severe, but in general, the burnout that was experienced in many countries, and this constant challenge to staff adequately all of our health systems, and the imbalances that exist there. And so when we think about the fact that we work deeply on a daily basis in 11 countries, we also, have influence very, in many other countries through targeted programs and initiatives that are built from and utilizing the Partners in Health model, and which is now over 40 countries have access. So we have and the NCD Synergies program, which is now the Non-Communicable Diseases and Injuries Poverty Network, that has expanded through the World Health Organization Africa Regional Office to be a model for all 54 African countries, and with targeted support in a number that I've noted there. We have a global project with End TB through Unit Aid, which is focused on demonstrating that the latest drugs to treat drug-resistant tuberculosis are safe and effective and should be the gold standard. And that project is wrapping up, but will be published soon. We also have the Harvard Medical School program in global surgery and social change, just to name a few, to demonstrate that the beauty and the magic that Paul left us in his insistence that as an implementing arm, as an NGO, Partners in Health, that we work on a daily basis with institutions that have expansive resources. How do we continue to leverage those resources for the movement for health equity? And that's what you see through this map. We're in the middle of so prior to Paul's passing, we had established a multi-year, 10-year vision and, a few pathways for action of how we as Partners in Health were continuing to move the needle on, in this movement, and really deeply focused on, 3 key pathways: strengthening health systems. So really that entire backbone of the resilient health system that we all talk about on a daily basis, ensuring that, what we've, come to term 5 S's, but what the WHO calls the 6 building blocks, for resilient health systems exist, and that not only are governments and donors and others building out budgets and plans that are based on the available envelope of funds, but really tracking the burden of disease and ensuring that all cases are being accounted for, and working kind of from a bottom-up framing of how do we actually achieve together kind of universal access to care or universal coverage. And so that's a lot of what we are doing with each of the governments in the countries where we work now. While we continue to do gap filling, with staff and medical equipment and supplies, we're simultaneously really sitting and invited with health financing and costing expertise and other lived implementation expertise to be influencing the next 10-year plans of a lot of our governments. Malawi, Sierra Leone, as we speak, are in the middle of this exciting effort together. We're also advancing the field of global health delivery, and that's really the work of University of Global Health Equity and a social medicine core competencies curriculum that we are, our colleagues are actually in Rwanda right now from all over the world working on finalizing, infusing, the Latin America social movements and indigenous teachings on social medicine with what Paul and Arthur Kleinman and others in the movement have left us. And so that's an area we continue to deeply engage in. And then certainly as we see the intersecting climate, economic, health crises impacting women and girls and children in general, adolescents, we're really also centering the needs and rights of women, children, and adolescents as much as we can in everything we do. And the way we're doing that is really through insisting that while we do this policy level work at governments, we're also really engaging in understanding the root causes and the historical context of why each of our countries and programs and patients are in the situation where they are. And so what's kept me with PI for all these years, and why I feel as though, you know, there's so much more to do, is that, you know, we deeply prioritize each and every individual. There's a Haitian Creole saying that every person is a person, and that philosophy and that mantra has been ingrained in me personally, from the 10 years or so I lived in Haiti, and then in Liberia deeply in community. But this idea that, you know, we're working at each of these layers of the system to ensure that change can happen. So really, right now, where we're seeing opportunities for systems change is a threefold. It's at the policy level, it's in the resource allocation, and it's in the governance and power structures level. So we've now set up our teams around the world to really simultaneously ensure that we're having influence at each of these levers and levels, at local, subnational, national, and global levels. And we're doing that certainly first and foremost through the care delivery and training, but also, as I was noting, through the accompaniment at national levels with policies, and then simultaneously really building long-term coalition partners and campaign strategies to work with within power structures, those that hold some of the purse strings. So we have a team that now works very, very closely with influencing legislation in DC. And so one of our biggest wins in that space was last year, as part of, as all of the Congress members and government officials were reaching out, you know, devastated that we had lost Paul so early, as you know, he was only 63. They wanted to make lots of symbolic hearings and notes, and, you know, mention his name in Congress and on the floor. And we said, that's lovely, thank you so much. And he would be honored, but he would be mad if we didn't push for more than just a symbolic plaque or a honoring on the House floor. And so our team deeply worked with our amazing friends, Representative Jan Schakowsky and Representative Raul Ruiz and Representative Barbara Lee. Ruiz was a student of Paul's and had worked with us in Chiapas a long time ago, and now works deeply on community health legislation. Jan Schakowsky had been to Haiti many times and been a longtime supporter and friend of Paul's, and Rep. Barb Lee had been so instrumental in the push for PEPFAR in the early days 20 years ago. And so they helped us deeply craft a resolution that's called the Paul Farmer Memorial Resolution. And that resolution, and I can send you the text as a follow-up for anyone interested, but it's really highly ambitious. It's our roadmap and what Paul had left us for how do we actually truly tackle some of these underlying systemic problems that are preventing, you know, so much of the health system strengthening efforts to have as much impact as they can. And so we never imagined that the resolution itself would you know, have full sign-on from all parties, but we were pleasantly, ecstatically surprised that thanks to our grassroots advocacy arm, Partners in Health Engage, which has 91 chapters around in 32 states in the US, mostly college and young professionals who've come, you know, who formed chapters of Partners in Health Engage to work with their local representatives and senators on influencing policy legislation, that they were able to get 35 House members to sign on, and then Senator Sherrod Brown and Elizabeth Warren and others have introduced a Senate version this year. And so we have this resolution that is calling for a tenfold increase in the amount of funding for global health from the US government. It's calling for better allocation of the existing funds that we do allocate through USAID and other funding to more government and local partnerships rather than all of the vertical kind of big funding that goes to a few key NGOs that have headquarters in the DC surrounding area. It calls for tackling illicit financial flows and looking at debt and tax justice, and it calls for reparations for health and really deeply, especially for countries that are still emerging from colonial structures. So just the terms that I named there and those 4 pillars, you can imagine that it was not everyone was ecstatic to sign on, but what it's led to is something I had never even imagined, and I don't think we would have sadly been able to accomplish if Paul hadn't passed last year. And it was this rallying cry and this understanding that his legacy will live on through work that obviously will be generational. And I'm now part of this middle generation who are bringing on the new generation and learning from the new generation in a really positive and exciting way. And so I tell that story because I think, the Paul Farmer Memorial Resolution is deeply focused on our recognition that so much of if we're going to really make systemic change, we can't just tackle the policies side, because there is money in the world, but it's not getting channeled in the ways that we know will have long-term impact on the communities that we serve. So it's that we sit in a daily basis of these deep paradoxes of, with a theory of change of care delivery, training, influence with evidence, and replication. We know we have to work with existing governments because we are working with the duty bearers of rights, the public sector. We also know that a lot of those governments are not working, for their people in the way that we think of the Haitian government right now. We are working with the public sector because we have to, but are we being protected and necessarily are we supportive of that? Certainly not. But we can't go around. And so many of our counterparts find ways to go around, and donors go around the system too, because they feel like if they send the funds through those structures, they might not exist in the same way, or they might not get the same outcomes. Excuse me, that's what I was trying to say. So my wonderful, amazing colleague, Dr. Joya Mukherjee, our Chief Medical Officer, said this as we were honoring Paul last year. She said, we might want to blow up the system. We might want to just shout and holler, but at the end of the day, we're standing in front of a person who needs food, a person who needs medicine, and it's not all about our politics. It's really about getting people the life-saving medicines and the care that they need. And so, through our collective radical optimism and rejection of cynicism, we're really, on a daily basis trying to deliver high-quality care while creating a paradigm shift amid systems that are often so rigid and resistant to change. So, in a recent example from last week, I don't know if any of you were following, it's not lost on anyone that Dr. Farmer was a very strong advocate for, the movement to end TB, a curable disease continuing to kill more than any other infectious disease. It's now, again, since the last year, COVID had overtaken it as the #1 infectious disease killer, but it's back on top. And so we've been part of a movement of, people who've survived TB, of governments, of health workers, of researchers, of advocates who've been really calling for some of the long-standing manufacturers of diagnostics and treatments to reduce their prices. And the Global Fund and USAID and other partners had been unsuccessfully trying to negotiate for many, many years, literally years, to reduce some of these prices, saying that even a small reduction would save many, would allow the governments of these countries to buy millions and millions more tests and therefore save millions more lives. Wouldn't you want, as a creator of a medication or a diagnostic, to be able to go down in history for saving as many lives as possible? And so we were not giving up. We joined forces with MSF Access Campaign, who've been on this effort for years. We had rejoined our colleagues from the Treatment Action Group, who were the former they became. They are the group that was ACT UP, that did all of the advocacy during the 80s and 90s, that led to the movement for access to HIV treatment around the world. And so, these are people who know how to do really good activism. So we had rejoined forces about a year ago, and we're really coming around. How do we do more of this access to medications? And we were deeply troubled by all that was going on with the inequities in access to the COVID vaccines, and said, we can solve this, we can tackle this. And it just so happened that our longtime friend and trustee, Partners in Health trustee, John Green, the author of The Fault Is in Our Stars, had also decided, he had promised Paul that he would, do everything he could to learn more about tuberculosis and make an impact. So he and his following of millions of Twitter and YouTube followers, maybe some of you who are known as Nerdfighteria, joined forces with us in a series of actions over the last year, not even year. It was just between June and September. And just in September, ahead of the high-level meeting on TB, John helped us, the global, the broader us, the coalition, raise awareness and attention to the fact that the diagnostics tests, molecular diagnostic tests that are the one gold standard for testing for TB, both susceptible as well as drug-resistant TB, remained, at a price that was too high for most governments to be able to buy, over $10 per cartridge. And so he and his creative forces of Nerdfighteria created tweets and memes and called the phone lines of Danaher, the parent company for Cepheid. And within 7 days of this constant barrage of phone calls, they actually worked with Global Fund and USAID to broker a deal where now going forward, there'll be a 20% reduction in the cost of those cartridges, which we were asking for a halving of the cost. It was time for 5. We were saying 5 instead of 10. And so it's a huge win. It's a great start, and it wouldn't have happened, sadly. And we talked to all of our colleagues at the leadership of Global Fund and USAID, et cetera, and they said, unfortunately, it was this outside kind of public pressure campaign, in addition to all the inside work that they had been trying and doing unsuccessfully for years, that finally led to this. So we're finding ways to continue to adapt, to work in coalition, to challenge the status quo, and to really I give that long-winded example because I think it's an important way to demonstrate in real time what this means and why it's so important. And the work that John took on wouldn't have happened if it weren't for his going and being and living in community in Sierra Leone, seeing the inequities, seeing the challenges that our colleagues and our patients were facing on a daily basis to access these modern medical advancements that should be available to all. And so if it weren't for Henry, who he mentions, a patient who had survived drug-resistant TB and so many others, he wouldn't have been able to even understand that. But using that platform to be able to really make immediate change was not anything we ever imagined, but we were excited to try. And I think we're all just coming off of that high still from last week. Taking a step back saying, okay, well, we have to keep going because the work is not done. But ensuring that the evidence that we were generating from the day-to-day care delivery work was infused in being able to tell that story and to make that influence was why all of these levers are so important. I'm going to close and open it for questions in a minute. But I wanted to just also share, why are we, why do we need to continue as the global health community to really deeply, not only, I'm going to go back to this slide, stay focused on high quality care delivery. Of course we do. We need to keep pushing for what's possible in every health system that we work in, but why we're also, really in this next phase of our work, deeply investing in technical and government accompaniment and the long-term justice advocacy work, because we feel as though all of these levers simultaneously are needed to really be able to impact real change. And so I hope that was a quick overview of kind of who we are and where I see the work going. And I hope it's led to many questions, and please, I'm open for challenges, for any kind of comments or questions as we move forward. I'll stop sharing my screen so we can see each other.
Yes, thank you so much for that amazing talk. So we have time for about, we have like 30 minutes for questions. So why don't we start with some HAPI students and then we can open it to other guests as well after.
So while we wait for people to formulate questions, let me just throw one out there, Cate. So one of your earlier slides talked about decolonization of healthcare, something like that. Could you explain what the point was there?
Sure. I think there's a lot of buzzwords going on around, especially in, in academic institutions in the global north around what does it truly mean to decolonize healthcare in a way, the way what we are really taking that deeply to mean, and what we mean by it when I put it on a slide is multi-pronged. First and foremost, a lot of what we have been doing, and certainly I am coming to you from Boston, from a position here in the global north, having been born as a Caucasian woman in the U.S. But part of deeply what our leadership model has been evolving around over the last 4 years since our CEO Sheila Davis took over is really how are we centering our decision making closer and closer to from as an organization as a whole, closer and closer to proximate to those who are suffering most, and how are we ensuring that it's not me and colleagues in Boston who are making the day-to-day decisions on where we work, what we do, how our funding is allocated in each country, but really our colleagues that are from the countries where we are. And so part of it is really decolonizing our own, decentralizing our own leadership structure, so that we do not have a headquarters, really at all. And we are known as the coordination site for moving resources and helping to make bridges. So that's part of it. But then there's also deeply the work of ensuring that our researchers and those who are, again, frontline workers are being trained in research methodologies and being first authors on papers, and that most all of our work coming forward, if you look at a lot of our published work over the years, it was Paul and our Haitian colleagues, or Paul and our Rwandan colleagues. But how are we really ensuring that those closest to the work, again, are being published and not just in local journals, but also in the Lancet and others. So that's part of it. And then certainly the act of setting up the University for Global Health Equity in rural, remote, mountainous Rwanda, not in the capital city, but really within a community of patients and that we are serving, so that those from that community can access the benefits of a high-class education, just as though anyone else would, is part of that movement. It's really working with long-term systems. And so I hope that helped answer some of what I meant there.
Yes, Dylan.
Hi, thank you so much for coming and talking to us. Your presentation was super interesting, and I think really relevant to a lot of issues that are sort of going on throughout the world at the moment. So I just had a question related to sort of the tactics used by pharmaceutical companies when it comes to evergreening patents. So I know specifically that Partners in Health was really involved in sort of getting Johnson & Johnson to put their profits aside on bedaquiline to treat tuberculosis. I was just wondering if Partners in Health has been involved in other efforts like that, or plans to be in the future, to sort of put pressure on pharma to put their patients first.
Yeah, thank you, Dylan. And absolutely, I think that we know that as we have engaged in these efforts for a long time. And if you look back, we've sat in this juxtaposition of working with corporations, as there are vendors, we buy from a lot of them to help, stock the shelves and fill gaps within public facilities throughout the world. But we also recognize that, as a organization, we have who works to ensure access to these medications, that we also have a platform and a real ability to influence here. So you're right, that was our first kind of public campaign with John Green and the Nerdfighteria, which had success in a short period of time in getting the Global Drug Facility, which is a global body that is providing reduced cost prices for bedaquiline to a number of governments, to ensure that they did not evergreen their patents, so that anyone, the generics will be able to be available when they come online. But unfortunately, that was not successful for every country, because some countries had already made agreements directly with, or they're not part of the Global Drug Facility. So a place like South Africa is actually has a lawsuit against J&J for trying to push this right now. And so we are planning as an organization to continue to use our voice in this way. Obviously, we believe strongly in what is needed to, we know, and it's not lost on us all of the R&D that goes into creating a medication. But we also know that the practice of evergreening patents prevents that ability to have competition and to increase the ability for more access. And so while we will continue to be advocates for, investing in research and we're not gonna shy away from pushing companies that have accessed a lot of public sector dollars for that research and in investigation to then uphold the focus on access. So thank you for that great question. I see a lot of other hands.
So, Anya, sorry, I'm just going to break in here for a sec because I do need to ask a follow-up here. Doesn't PIH also, correct me if I'm wrong, take contributions from pharmaceutical companies? And how do you reconcile that? And has it, have you hit any resistance in sort of in working to lower drug prices at the same time that you're taking contributions from pharma?
I'm not going to shy away and say that we don't find ourselves in a challenging position, because unlike some of our peer organizations who, publicly do not make partnerships with pharma, we do in some of our funding. Does some of our programmatic funding and partnership does come from some of these corporations. And we have, of course, deeply considered the trade-offs, and the work that we do in the advocacy space is very, very, very focused, and the work on a certain few key issues, and does not have any overlap with the day-to-day care delivery work. And so we have organizationally really focused on how do we continue to push for what is good, while also hopefully simultaneously, first and foremost, being welcomed and invited to to engage with corporations in conversation on how they could expand access and be trusted partners there. We don't want to have to publicly engage in other tactics if there's a way to be able to work together. And so it's an important consideration, and one that we are sitting with on a daily basis. But we have a long history of doing this. We had stood on the outside of Abbott Pharmaceuticals questioning years ago some of their work, and they have been one of our longest term, strongest partners in Haiti, having helped us actually set up a production facility to make ready-to-use therapeutic food for treating malnutrition in rural Haiti. And so, I think we owe it to the movement to to continue to engage, but also to ensure that as we are welcomed, to really have conversations with our partners in that space.
All right.
Emily?
Yes, Emily.
I'm sorry, I didn't mean to, excuse me.
Thank you. And thank you so much for taking the time to come and speak with us. I think just as at least personally going through these courses and just like understanding how when it comes to health, there's so many like interlocking factors and things that kind of compound. And so just hearing your presentation, it was really interesting, but also recognizing that you're trying to deal with so many different issues in so many different places, which also impacts which issues are more important. Yeah. How do you kind of go about as an organization prioritizing and making sure that things that are, of course, everything is important, but I think that's kind of like the exhausting thing about health is that everything is important. So,
Absolutely.
how does that kind of happen in your workplace?
Such a good question. Oh my goodness. And I think absolutely one that we, like you said, that we face on a daily basis. I think, for me personally, you know, now working deeply on with all of our programs, teams, really working on, okay, what are the common threats that we're really trying to tackle together? It's really long-term health systems, financing, and the kind of combating this kind of what we often say socialized for scarcity, imagining that, certain health systems are never going to be able to have all. So why would we even imagine for all? And so a lot of what we end up doing is saying, okay, where we're going to put our organizational energy in is um, is really focusing on the methodology and approach for how how policies are even being conceptualized. So, Malawi example. Yes, we are working in primary and secondary care in NCDs, in HIV, TB, maternal child health, the full package of care, that you need. But we also simultaneously seconded a few key implementers to the government and said, you want to have one plan, one budget, one report. That's the goal of the government. How are and you're saying you want to deverticalize all these programs. Well, how do we do that? How do we ensure that the building blocks, the essential building blocks of the health system are there, and that this kind of, I don't like to call it minimum standards, but this kind of essential package of services are billed as kind of non-negotiable. They have to be prioritized. We know there's a lot of other things that need to be existing someday, but aren't going to have to be able to all be there. So we do a lot of work around how are we prioritizing based on kind of an equity lens, based on a patient-centered approach, based on a family-centered approach, not a one vertical disease area. And then I also think that we often, we are not the organization that is traditionally likes to say no, but we have been very, very strategic, and we could have been working in 200 countries, right? But we are working deeply in 11, and I think that is because of the fact that we have said that we make long-term partnerships with, and we will work ourselves out of jobs as we go. But we've also really said it's better to do deep work and do it well and demonstrate what's possible rather than trying to spread to many, many countries and only have a smaller impact per se. So I think that's a lot of how we've prioritized. I also think that we're constantly prioritizing initiatives that and funding opportunities and programming that again allows the strategy that we've set to be able to continue rather than kind of chasing what the money says it should. I hope that helps a little.
Yeah, that was really helpful. Thank you.
All right, Kundai.
Hi, thank you so much for your presentation. I found it interesting that you have work in different countries as well. I was wondering if at all, if government structure has an impact on how you do your work, whether it helps you a lot or whether it gives you a lot of roadblocks, especially when you see the structure of government in the United States versus the structure of government elsewhere. What sort of advantages and disadvantages have you faced when you're trying to deal with influencing government policy from two different completely structures?
Amazing question. Oh my gosh, yes. You absolutely opened so many thoughts in my mind. I think I'll start with it deeply impacts, right? Of course. If the philosophy that you're starting with is that you're to accompany a public structure, and then that public structure might actually be actively fighting against the people that you are serving. And a case in point, in Immokalee, Florida, Immokalee is a community of rural migrants, migrant farm workers mostly from Haiti and Guatemala. And they work on our farms that provide much of the, a lot of the food for that we buy in the grocery stores. And during COVID, because a lot of them are undocumented immigrants, they were not being recognized by the Collier County Public Health Department for being considered for vaccinations, for being considered for any of the social programming, of course, that any of the government benefits that might have been coming. And actually, just this past year, the government of Collier County actually was being offered money from the CDC Foundation and the CDC in Atlanta to expand access to these communities. And the citizens of Collier County, as well as the public health officials, actually refused to accept the money. And because they didn't believe that people, these community members should be vaccinated, that they should not be, they didn't have the rights, that they just, and did not need to be protected. So, in that community, while we do work with the Collier County Department of Public Health when we need to, we work more closely with a few community-based organizations that have been long-term partners in the community that have been very well respected, a social services program to ensure that families have access to monthly direct cash transfers to, and we're able to set up a network of community health workers to help those communities be vaccinated. That's here in this country in the midst of, of a government system in Florida that has actually, really, not shared in the scientific understanding of how COVID spreads and how it can be treated. So that's one example. And then I'll give a positive example. Like, we've made much more progress in how we've evolved as our programming in Rwanda than any other country, because the government of Rwanda has prioritized health from day one. And so since we've been there, we were invited in 2004 to start working with the HIV program. We do no longer have to do any HIV programming because the government has taken on all of the that program. And we only do gap filling for kind of specialist physicians that aren't existing in the current public system. We've been able to scale up multiple programs and initiatives in Rwanda through the government programming in all districts, because we were able to demonstrate, okay, here's what it costs, here's what it takes, here's the package of care, and they ran with it. They brought partners along and made it happen. And they've also had a social community insurance system that has really increased access for primary care services for all. So that's one extreme. And then we have other extremes. And so, the act of accompaniment is challenging. It's always more complicated than we know it would be to kind of just work in your own private facility, do your own thing, set up your own system and make it happen and say, this is the gold standard. But we know that ultimately that doesn't achieve our mission and goal, which is really for the public sector to take on. And so we're going to keep I think a lot of other positive wins are when some of our colleagues get accepted to serve in government positions. So they get appointed as a department director for NCDs or for health. And so then you have influence in that sphere. We have Partners in Health alumni who, Dr. David Walton, who's currently serving in this administration as the president's malaria coordinator. For the President's Malaria Initiative. He was one of Paul's first students. And so finding ways to also influence through positions of in governments has been a tactic that we're using as well, to varying degrees of success. Yeah.
Thank you.
All right, while we wait for potentially another volunteer, I have a question that is building off of Kundai's. Have there been, just because I think something that makes PIH really stand apart from other global health interventions is how it works with local governments, and it makes these interventions so much more sustainable. So first of all, how do you go about at the beginning building these governmental relations at the start, at the get-go? And then have there been any countries where PIH has tried to implement an intervention but couldn't because countries were either unwilling or unable to partner?
Great question. In every case, if we look at the history of how we entered into a partnership in the countries where we are, it was because we were invited. And so in the case of well, I shouldn't, that's an overstatement. In the 5 African countries where we work, we were invited by the government. So Sierra Leone, Liberia, I mentioned, were in the midst of an Ebola emergency. We were invited because they knew we wouldn't just get engaged for a short period of time, but we'd really work on longer term systems. Rwanda, Malawi, Lesotho, again, we were invited by those governments in the middle of the heart of the HIV, it's 2005, 2006, 2007, when access to treatment was just becoming available through PEPFAR and Global Fund. Peru, Mexico, were a bit different. They were based on personal relationships that Paul and others had. And so, when we were invited to rural Chiapas, where the Zapatista movement was, it wasn't necessarily because the government wanted us there. And so now we work very closely with the public sector and the Ministry of Health in their health facilities, and are deeply engaged in strengthening those systems. Peru, it was a relational connection, but quickly the government realized, when the Minister of Health's daughter was suffering from drug-resistant TB, a young daughter of age of 5 or something, and we were able to cure her, that this organization was here to accompany and to support and help. And they now 28 years later or 26 years later, in Peru, we work very deeply with the Ministry of Health, not only with their TB programming, but certainly across the board. And so I do think that much of what we've learned over the years is that government relations are essential at all levels. And we've mostly traditionally worked with government officials at the Ministry of Health facility where we work, or at the districts where we're implementing, and hadn't had as much national level engagement. Rwanda was different because of many, the government was just so engaged from the beginning of our partnership there. And the former Minister of Health of Rwanda, Dr. Agnes Minagwaho, was our first Vice Chancellor of the University of Global Health Equity. But we found that, or I've found personally through my experiences accompanying ministries of health, both in Haiti and Liberia, most deeply, that it's really, it's the long game, it's daily presence, and it's demonstrating through pragmatic solidarity, not just oh yeah, I'll sit there and help you, type up your notes from the day, but which is also pragmatic, of course, in and of itself, but also being able to be a go-to partner if a partner is struggling to get fuel for their ambulance, or to ensure that one of their staff can get to the district to be able to distribute the vaccines for the day, offering a ride, things that are that simple and easy, and building relationships that are built in mutual trust, and not saying yes all the time, setting boundaries, but also, very, very pragmatic in and of itself. So I think I could go on and on and on, of course, about kind of what it takes to work with governments. And we're actually in the process as we speak of kind of documenting some of the ways that we approach our work with governments and what we mean by accompaniment, because we have recognized that so many groups do technical accompaniment and advising or consulting and are invited with contracts to do so. And we're also finding that more and more we're being called to do that. And we're wondering why. And what is it? What is that kind of secret sauce that is demonstrating a different way of doing things that isn't kind of the come for 2 weeks and come and jump back out kind of model? And why is it so important to simultaneously, when there are so many needs in the care delivery, to also invest in these areas simultaneously? It's always a cost benefit analysis.
All right, thank you for that answer. I think that we have time for about 2 or 3 quick questions. So Maggie.
Yeah, thank you again for coming to talk with us. Could you talk a little more about kind of your work on the ground, living and working within these communities, and kind of what you think the best way to encourage these meaningful connections while also avoiding the kind of colonialist mindset you had mentioned earlier? Because it definitely seems like a very delicate balance that I think this organization has done very successfully. Yeah, I'd love to hear more about that.
Great question. Wow. These are like the best questions I've ever received. Thank you guys. This is amazing. It's not lost on me that I'm coming at this from like someone who has who was invited into Haiti as a young person who did not. I had studied Haitian history, luckily, thankfully. I did not speak Creole. And reflecting back, I think it was, I knew I was entering with humility, that I knew nothing, that I was there to learn, that I was there to listen. I think a lot of times people get like a title and they're like, oh, you are an expert in so and you're like 22 and you don't, nothing against amazing 22-year-olds, of course, please. But I think of myself when I was that age, and I certainly was just starting out and was there to to help collect some data and help listen and learn and kind of build bridges and build community. That was how I kind of approached it. And I think that reflecting back now all these years, that kind of mindset of I'm here to learn, I'm here to listen, I'm here to support and understand is not how everyone approaches things. And I think it has allowed for me personally to constantly analyze, okay, am I what I'm doing on a daily basis, is this actually helping, or is it taking up space from a colleague that could actually be from the local community who could be paid to do this work? So I worked myself out of literally hundreds of jobs, which is wonderful. And secondly, how are we, you're right, like there is a role for, skill sets from all different communities and, and areas in this movement. So how are we creating, constant opportunities for learning together and sharing that aren't like this challenging power dynamic of privilege, etc. I don't have the answer. I'm sorry, Maggie, I really don't. But I think, we've constantly tried to really center our organizational resources towards, creating long-term training programs, family medicine residency programs. We certainly have residents that come from the US, to work, to fill gaps, but really they're also focused on teaching in those cases. So how are we constantly accessing specialist skills while kind of creating a dyad? It creates it's more resource intensive because you have to double finance some things, but we feel, and I feel personally, for the long term, the way that we're truly going to kind of really build the systems that our colleagues are asking for, that they want to see. We're not telling, they're saying these are the areas that we need support.
All right, I think that is all we have time for today. Thank you so much, everyone, for your questions and for your answers, Cate, and your amazing presentation. And thank you, everyone, for coming.
Thank you so much for having me and for the great questions. Really appreciate it.
Yeah, thank you so much, Cate. There was one question in chat we didn't have time to get to. I'm sure that they could send you an email. It was about
They absolutely can.
pharmacy and what PIH does. So we really don't have time. We thank everybody for coming today for what was a very stimulating discussion, and one that was well worth all the maneuvers that we had to go through in order to figure out a date for you to be here, etc. So thanks again, and perhaps we'll see you here again at some future date. Take care, Cate, and thank you.
Wonderful. Thank you, Adam. Thank you all so much. Thank you, Adrian, all.